The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hi, everybody. Welcome to TMD Demystified live stream. I'm Tony Urbanek. Glad to have you here. I hope that what we cover today is meaningful to you. And if not, then that's okay too. Last week, which I covered last week, I discovered the presentation that I made to the National Academy of Medicine, Engineering, and Science back in 2019, bringing to the attention of the Academy, which was an august group of scientists from all disciplines who were brought together in Washington, D.C. to discuss basically why there has not been any progress, significant progress, on the understanding and treatment of TMD, temporomandibular joint disorder. There's only one disorder, not multiple disorders. That's my opinion. In the United States over the past 50 to 70 years. And I played my presentation, 7-minute presentation, to that august body in hopes that they would continue or at least look into the research associated with chronic inflammation as the primary cause, the linchpin, the common denominator cause of all of the symptoms, which is actually what I had discovered when I did my own research after I quit doing temporomandibular joint surgery 15 years ago. All that information is already on the internet, is already on completely covered in my now 249 podcasts that are published both on YouTube and published on Dental Town, again under the name of TMD Demystified. But the history behind this, my quote discoveries, which really weren't discoveries, there was no whole cloth discovery. I just brought to my own attention and then the attention of the National Academy of Science, Engineering, and Medicine, the fact that chronic inflammation can create painful symptoms distant from a damaged joint, which has been in the literature now for actually over 100 years, starting back to 1906. And I've talked about the articles over the past couple decades, very good articles that have brought this to the attention. The problem is that the dental community, the dental industry, does not look at it that way, and it's particularly the profession of and the specialty of oral and maxillofacial surgery, who has the bias to do surgery on these joints. Now, admittedly, I am an oral and maxillofacial surgeon. I'm very proud to be a very oral maxillofacial surgeon, and actually was one of the very first double degree, meaning both dental degree and medical degree, oral and maxillofacial surgeons minted in the United States of America back in the late 60s and early 70s. Actually, I was, I believe, the 9th double degree oral and maxillofacial surgeon, minted, trained in both surgery, and went through both dental and medical school. And I myself also have degrees in cell biology and anatomy, and 2 years as a fellow with the National Institute of Health, National Institute of Dental Craniofacial Research on facial growth and development. That's my background. But 15 years ago, I decided, for very good reasons, that TMJ surgery of any kind, of all kinds was not going to be the correct way to handle TMD, temporomandibular joint disorder, over the long term. And I had done, in the first 36 years of my 50-year career as an oral and maxillofacial surgeon, over 2,000 temporomandibular joint cases, half of them what we call open joint cases for the public who is listening. An open joint case is an incision in front of the ear where you get access to the joint itself visually, and half of them through an arthroscope using a television screen and a scope inserted into the joint, just like orthopedic surgeons do arthroscopic surgery on joints. We did that for years, for decades, on the temporomandibular joint. But after doing 2,000 temporomandibular joint cases, I decided, for good reason, that this was not going to be the way to go. I had plenty of other kinds of facial reconstruction to do: microneural surgery, cleft palate surgery, bone grafting surgery, orthognathic surgery, certainly a bunch of traumatic surgery, cancer reconstruction. But the TMJ surgery I put aside and quit doing it because a third of my patients would be back within a year or two with the same symptoms, no matter what procedure that I did, including total joint surgery. Total joint surgery, total joint reconstruction, it's classified or noted now as a TJR. You might hear that, the TJR, total joint reconstruction. Actually, just like orthopedic surgeons put a artificial joint into the knee, there is two companies that make artificial joints, total artificial joints for the temporomandibular joint, at which point we are going to begin to dissect that in the very near future, beginning with this podcast, with this live stream. We're going to begin talking about that. And then I'll let you make your own decisions. But my mission, my stated mission, is to bring a real solution to TMD before the public and before my colleagues. And that is one of the problems that is out there, is my colleagues in all areas, especially oral and maxillofacial surgery, who has the bias to do surgery on these joints as a solution, and others who want to do things that just treat the symptoms rather than the cause. Because if you can make the cause go away, you can make the symptoms go away, so why treat symptoms? And if you make the cause go away and you can do that over a long period of time, why would you need surgery? And I can prove all these statements, and I'm happy to do that. Almost all of it is already in one or more of the podcasts that I've already created and recorded. But today we're going to take a continued dive, as they say, into the discussion and the conflict that between the oral and maxillofacial surgeons who feel they need to do surgery on the joint as a solution for TMD, and myself and others, I'm not alone, who feel that non-surgical treatment is the way to go. And what I, quote, discovered, but just really connected the dots, is that, as I said again, and is explained in many other areas of my podcasts and things that I've recorded, that chronic inflammation creates all the symptoms directly, not indirectly. And that is already in the peer-reviewed literature, how chronic inflammation in any joint will create a signal coming from the brain stem for the muscles that move that joint to become tight, to tighten up so that you don't move the joint, hold the joint still, allow it to heal. And that is the actual mechanism that creates the painful symptoms of TMD. The non-painful symptoms work through a separate mechanism, but non-painful symptoms being what the ENT doctors know as Meniere's disease, and they know it is defined as the symptoms themselves: ringing in the ears, subjective hearing loss, a feeling of fullness in the ears, and dizziness. Those three symptoms are called, by definition, Meniere's disease, and the ENT otolaryngologists have no solution and admit they have no solution for TMD, but we know absolutely, and anyone who treats or sees, even peripherally, patients with TMD also know that a good portion of those patients complain of ringing in the ears, subjective hearing loss, and vertigo. And when you make the chronic inflammation in the joint go away, just like it makes the pain go away, it makes the non-painful symptoms go away: tinnitus, subjective hearing loss, and vertigo. All right, with that as a preliminary primer to what I have to cover today. And again, today, like other episodes of the live stream, I am open for discussion. I'm looking for anyone who would like to ask questions, make comments, or even criticize. I'll be happy to respond to criticism for anyone who would like to join the chat, put down a question or comment, and I'll be happy to bring it to the rest of the public watching. I know from the last few episodes that we haven't had any so far, or we had a few at the beginning, few questions at the beginning, but we certainly haven't had any substantial criticism or any criticism at all of my comments, and we have not had many questions so far, but I encourage any watchers to question. But after we finish the first 30 minutes or so of my presentation, if there aren't any other live stream viewers who would like to make questions or comments, then we'll wrap it up in 30 minutes. But the mission is to bring a real solution to TMD, a non-surgical solution to TMD without surgery, and to bring to the attention of the public what is really transpiring out there. And some of it, this is inside baseball, and I'm just going to bring it to your attention and let you make your own decisions. So it's very ironic, very, very, very ironic that last week I decided that I was going to let viewers view my 7 minutes in Washington, D.C. in March of 2019, and my presentation basically asking, almost begging, the august group of scientists in the room to look to chronic inflammation as the common denominator, and the best way to decrease common denominator is to rest the joint, and that is with a device that unloads the temporomandibular joint like a set of crutches unloads a knee. The speaker who followed me was a doctor that I know relatively well by the name of Gary Bulow, and he is the division chief, Division of Oral and Maxillofacial Surgery, Department of Surgery, Emory University School of Medicine, Atlanta, Georgia. And he is the speaker that followed me directly. So again, my mission is to bring out the facts of this problem as they are, and I'll let Dr. Bulow speak for himself in the roughly 5-minute presentation he made directly after my presentation to the American Academy of Science, Engineering, and Medicine. And then as I go through this, I may stop his presentation at certain points because I have comments. I don't want to miss the opportunity to bring some things to your attention about his presentation. He speaks for himself, and each of us is allowed to do that and should do that. But he speaks rather rapidly. So there may be some times I want to stop in the middle of his presentation, not wait to the end to make a few points about what he is saying to the group in present, and about the ramifications are about the differences in opinion and the differences in the science between what oral and maxillofacial surgeons have to present and what I present about this problem. And in his presentation, he not only represented himself, he is associated with Emory University Department of Oral and Maxillofacial Surgery, but he, as stated, he represented in his presentation the Society, American Association of Oral and Maxillofacial Surgeons, of which I am a member and have been a member for 50 years plus. So I am also a member of the American Association of Oral and Maxillofacial Surgeons, and I'll probably have a comment or two about that before we end here. But let's, first of all, let's hear what Dr. Bulow has to say. I'm going to share my screen, and then we will see what he has to say if we can get this started.
Thank you for the opportunity to present. It's always been and has been a very educational day for me. I'll try and be brief. I'm a professor at Emory University and director of the training program down there, and I've spent, I guess, 20 years in the clinical aspects of managing temporomandibular joint dysfunction. To start first, I'd like to say thank you to Jennifer, Tricia, Lisa, Michelle, and Alexandra. The stories really are heartfelt and truly appreciated. It really tells a very sad story. There's a very common theme amongst the majority of the patients that have spoken today, and that is the multiply operated joint. We know and have known for a long time that really bodes very, very poorly in terms of outcomes. And it really is a sad tale of iatrogenic injury. I would like to think that in today's world and with our current research that no one would ever consider doing and going down those roads that you've been asked to go down. I know that would be the case at Emory and many of the academic centres, but I wish I could speak to everyone who does TMJ surgery in that regard.
So I'd like to stop it right there for a minute. Again, I apologize. I was hoping to make this more fluid presentation, but I want to make the point that Dr. Below specifically talks about the multiple operated joint. And I certainly agree. There should be no significant reason, no reason at all why if you do temporomandibular joint surgery, you should have to do the surgery again, which is exactly why I stopped doing temporomandibular joint surgery. A third of my patients would be back within a year or two with the same symptoms, and I did not want to do a second operation for them. That is the reason I stopped doing temporomandibular joint surgery on the temporomandibular joint. And Dr. Below correctly says there's no excuse for that. And there'll be some things I say about the multiple operated joint later on in comparing what the American Association feels and how the direction of Dr. Below and one of his associates who is closely associated with a company that produces a total joint replacement. And a total joint replacement, as I said earlier, is a very complicated operation. I've done many of them. It has many potential complications associated with it. It is not 100% successful, and it is less successful in hands of doctors who don't do many of them, and I did many of them throughout my career as doing surgery on the temporomandibular joint. But my point, besides that there is no excuse to have to do a second operation, the fact is there is no reason to do the first operation if you can get rid of the inflammation which causes all the symptoms. And that is my position on this. So I'll let Dr. Below continue his presentation a little further.
Sorry. Multiply operated patients end up with neuropathic pain, they end up with centrally mediated pain, and that just can't be ameliorated by additional surgery. We know that, and we have to be very careful in terms of preventing that. I think iatrogenic injury, as has been reported here, is preventable. And to that regard, being on behalf of AMOS here and the American Society of TMJ Surgeons as a group of us, I think we would all strongly support the development of guidelines both for TMD diagnosis and for TMJ surgery. And I think we could get that adopted by both AMOS, ACOMS and ASTMJ, which would represent 10,000 oral maxillofacial surgeons and really cover 95% of individuals who practice in this country. I think we'd all be happy to work towards that.
All right, so let me stop right there. First of all, this presentation was made 7 years ago, and long before then, the oral and maxillofacial surgeons in the country, of which there are roughly 6,000 oral and maxillofacial surgeons, almost all of them, the vast majority of them, at this point in time, 2019, had already stopped doing temporomandibular joint surgery of any kind because they had the same findings that I had. At least a third of the patients would be back within a year or two with the same symptoms. But that doesn't mean that doing a single surgery is the answer. And certainly, if you are a proponent of total joint reconstruction, it is definitely not promoted because temporomandibular joint total reconstruction is a very complicated surgery. So, I'll let Dr. Boulot continue.
A couple of other issues, the devices that have been talked about here with the Proplast, the Vitek and Christensen, these are all devices that were grandfathered by the FDA. They never went through pre-marketing applications, so they were never validated. They've all been removed and no longer FDA approved. That is very different to some of the current devices in terms of TMJ Concepts and the Biomet device, both of which gone through pre-marketing evaluations and both of which just completed post-marketing surveillance that's mandated through the FDA.
So Dr. Boulot is a spokesman. I have researched it out, and he is a spokesman for one of the TMJ companies that make a total joint device. And I think, my opinion, I think his presentation speaks for itself in his support of total joint reconstruction, and we'll let him continue.
The FDA has already accepted the Biomet post-marketing surveillance, and the data thus far has shown that the initial outcomes presented in the initial pre-marketing applications have been sustained in the post-marketing surveillance. And in terms of duration, these joints are now at more than 20 years for both of them. So hopefully it bodes a little more importantly for a positive future. It remains crucial to make the correct diagnosis. I've written as an editor about complications related to TMD, and one of the biggest pitfalls in TMD is making the incorrect diagnosis and then going down a surgical road that is completely inappropriate for the diagnosis. We require a lot more education in that respect. When it comes to that, making an Axis 1 diagnosis is relatively simple if you have the experience and you work with that DC-TMD form. It's very, very influential. What would be beneficial to the surgeons and the associations that represent the surgeons, for those particularly not in an academic setting, I think it would be very helpful if we could develop a questionnaire or a screening tool that would help individual surgeons and academic centers to identify some of the Axis 2 and some of the cluster problems so that we can work out which patient might not be the best candidate for surgery. And then we can limit surgical intervention to something like arthrocentesis or arthroscopy, a relatively safe and simple procedure without unduly causing any injury. But that would be most helpful. In terms of literature, in terms of outcomes from our procedures, which have been documented for many, many, many years, I would have to say there is a reasonable amount of robust literature that shows good outcomes from arthrocentesis and for arthroscopy. These are cohort studies, almost impossible to do randomized clinical trials when it comes to a surgical intervention. It's just not doable. When it comes to total joint replacements, I will let the post-marketing surveillance as it appears really give you an indication as to the outcomes. But I think most of us are relatively confident that joint replacement in the right individual by the right surgeon given the right diagnosis is a very reasonable approach. There are some challenges with arthroplasty, and we need much more research in terms of discectomy versus temporalis fascia flaps versus fat flaps versus some of the tissue engineering, which may provide further opportunities for us. And I look forward to collaborating with many of the centers. Research is a problem, and trying to get funding from PCORI and NIDCR and NIH is a true nightmare, and I've applied for many of those. And because TMD or TMJ surgery falls in a very small cohort of individuals, funding is always problematic to obtain. It's very different from orofacial pain. We're talking TMJ surgery in that small group of TMD patients who benefit from surgery. And the last thing is that we are trying, and we're already advocating and moving towards doing two things which I think will impress and hopefully make the committee and the patients happy. We are establishing a TMJ registry, just as been done in Australia and has been done in the United Kingdom. We're working on it, and by the end of this year there should be a TMJ registry for total joint replacements. Number two is I'm working towards evaluation of total joint replacement hypersensitivity. It all depends on grant applications and whether it's funded, but we're working towards identifying whether hypersensitivity really does correlate with poor outcomes. And keep in mind, as a last note, I know I'm 20 seconds overdue, we're talking about small numbers. When you talk about last year, and I sit on CODA, the Commission on Dental Accreditation, as do most of my colleagues, we're talking within academic centers of 102 programs in this country, 4,500 procedures were performed in 2018. only 4,500 in academic centers, and I'd like to think that we do the most. So it's small numbers to work with, and that's also problematic from a funding point of view. But I look forward to working with as many people as we can to make this a better outcome for the patients. And I wake up every day to go to work to try and make a difference to you all. Thank you.
Thank you.
All right. Now, if I can push the right button and came back up here. So I let Dr. Berlow speak for himself. So that was 7 years ago. Since then, the American Association of Oral and Maxillofacial Surgery has come out with a position paper based on what the entire association, and by the way, this position paper, the lead author is Dr. Berlow, who then came up with a position paper for all of the oral and maxillofacial surgeons in the country as to what they need to think about and do regarding temporomandibular joint surgery. So I just want to read one little piece of it. I will make this position paper available to anybody who wants to contact me, that's for sure, no problem. So one of the positions that American Association of Oral and Maxillofacial Surgeons had at the bequest of Dr. Berlow and several other authors, he's not the only one on this paper, is to initiate the least invasive, evidence-based evidence-based non-surgical or surgical treatment. And I'll read this paragraph verbatim. Non-surgical treatment for the management of temporomandibular joint problems, IPD, may include rest, heat, ice, non-steroidal anti-inflammatory drugs, muscle relaxants, physical therapy, and orthotics, meaning a device that goes in between the teeth. Orthotics, that's the device that goes in between the teeth. Today in 2026, half the dentists make a night guard that's classified as an orthotic and give it to the patient and hope the patient doesn't come back. And the other 50% of dentists, 49.99% of dentists don't want anything to do with TMD. I've said that many times before. And then there's this small percentage of dentists who do try to treat symptoms various ways, one way or another. But today we're focusing on the surgeons. So their own position paper states that orthotics is an appropriate way to treat and initiate the least invasive, evidence-based, non-surgical care. And what I found is that if you make a device that separates the posterior teeth over a period of time, according to protocol, that you get the best results. The problem is that I brought this not only the attention of the Academy of Science, Engineering, and Medicine, which then wrote a consensus summary report, of which my information was not included. I was hoping it would be, but it's not. I was denied 3 separate times presenting this information of my own independent study. This is not my study. I took 3,000 patients that I had treated with a device and protocol that separated the posterior teeth, according to the protocol, 24/7 for 2 months, nighttime only the rest of the life, and funded a independent study overseen by a IRB through Middle Tennessee State University, and their findings were extremely validating. The patient satisfaction was 85%, meaning 85% of people who had TMD of the 3,000 in the study, and then they had to work out people did not qualify to be in the study, but 85% of those were very satisfied, meaning they must have got significant results. And actually those included people who did not follow the protocol completely. So I particularly claim a validation level a little higher than 85% because the people in the study included people who didn't completely follow the protocol 24/7, nighttime only for the rest of your life. But my point is that the American Association has the position in their own position paper that orthotics are appropriate and necessary before any surgery is done. We have a validated scientific paper that says success rate is 85% or above. And the American Association of Oral and Maxillofacial Surgeons has denied me, a member, card-carrying member of the American Association of Oral and Maxillofacial Surgeons, 3 separate times to present this information to them, to the organization at a national meeting. The first 2 times I went through the usual customary way that we, as a member of the association, has the opportunity to present whatever they want, a finding, an experience, different ways to do that. After the second time, I was denied to spend an hour at one of our national meetings presenting this information to, usually there's 1,500 oral and maxillofacial surgeons who come to the meetings. I complained about it to the association, appropriate association member, and they said, Dr. Urbanek, we're really sorry about that. Just do something simple and we'll get your feet in the door and then you can expand on that. And so, as usual, I applied for a short, very short opportunity, 5 minutes, a 5-minute opportunity to present the basics, quickly present the basics of what I had discovered to the association, members of the association, and that also was denied. So I just bring that to the attention of any of my colleagues, both in the oral and maxillofacial surgery arena, my dental colleagues, the ADA, and the public. Those are just facts and can be verified. And then you have to say, well, why? I'm gonna leave it at that. I have my own opinions on that, and I will maybe at a later date speak on my opinions, talk about my opinions. But as this rolls out, I think that my mission is even stronger, and my purpose is even stronger to bring this information out and let things happen as they're going to happen. All right, so with that said, what I know is that there are no live stream viewers right now, but I know that after we edit this into its final form, that we have many people who watch our live stream later on. I will allow any questions they want to contact me independently. Certainly I'll try to answer those, respond to any questions that you might have regarding this. And with that being said, I'm pretty much finished for today's live stream. I hope that this information is valuable to viewers, whether you be an oral and maxillofacial surgeon, whether you be a dentist, whether you be a public who has temporomandibular joint disorder. I have a lot to say about the meeting itself. I think there are many other speakers that were at this meeting that had the opportunity from the public to speak. I was one of them. Dr. Below was another. He was classified as a member from the public. The people seated, the doctors seated, were in the discussions about why temporomandibular joint problems have such little result, why there has been such little progress on solving this problem. That went on for quite some time. But at the end of the meeting, there were probably 5, 6, or maybe 7 people who were allowed to speak from the public. I was one of them. Dr. Below was one of them. So we'll leave it at that. We're into 35 minutes right now. I apologize again for the complication I did by pushing the wrong button. And I look forward to our next live stream, which will be in a week on a Saturday at noon. And I also encourage anyone who wants to look into this deeper. You can go on the podcasts on Dental Town, TMD Demystified, or they're also on YouTube. With that being said, I look forward to the next time we're together. And I am Tony Urbanek, and this is TMD Demystified.